So good afternoon, respected all the delegates present on and off the dais. Good afternoon to all. My topic for presentation is visual rehabilitation and quality of life with corneoscleral lens in patients with irregular astigmatism. So I have no financial disclosure. So the rehabilitation of patients with irregular corneas is very challenging, and it was previously done with lenses such as rigid gas permeable contact lens and later rose scale lenses. But however, corneas with very high keratometric values, these lenses are not very well tolerated. Hence, scleral and corneoscleral lenses are a better option. So as far as treatment option of irregular astigmatism is concerned, contact lens is a far superior solution, and more specifically, the scleral lenses. You can see in this picture, it's very much designed to vault over the irregular cornea, and it holds a liquid reservoir of non-preserved saline, and it lands on the sclera. And all the scleral lenses has an optic transition and a landing zone. So this is a video where you can see how the scleral lenses, they convert the irregular corneal surface to regular surface by maintaining a fluid reservoir over it and provides a sharp vision by neutralizing the astigmatism and improving the visual acuity. I give the video credits to Col.Rangachari Laboratories. And the aim of my study is to assess the visual acuity achieved with corneoscleral contact lenses in patients with irregular astigmatism. And my primary objective is to assess the improvement in visual acuity and the number of visits taken to achieve the correct fit of these lenses. And my secondary objective is to assess the quality of life and patient satisfaction using a questionnaire and to record the complication. And the materials and methods, it was a prospective interventional study done in 32 eyes of 24 patients for a period of 1 year from July 2021 to 2022 in a tertiary eye care center. And my study population include those with corneal ectasias and post-LASIK ectasias and post-keratoplasty patients with irregular astigmatism. And the sample size calculator was 31 according to the following formula. And informed consent was taken from all patients, followed by a detailed ophthalmological evaluation, which included refraction, keratometry, and tomography, and followed by contact lens fitting. And the selection of for the contact lens fitting, we have to select the first trial lens, which is based on the cornea profile of the patient, followed by the fitting evaluation. After the lens is fitted, we check for the central fitting and the peripheral fitting. For the central fitting, we see for the tear reservoir. That is, as told earlier, there will be a non-preserved saline, which is mixed with sodium fluorescein. In other words, it's called the vault of the lens. So anywhere the central vault should be between 200 to 400. If it is less or high, we steepen or flatten the base curve accordingly. And for the peripheral fitting, we look at the lens landing. If there is excessive movement, we reduce the landing zone. If there is impingement, we increase the landing zone. Once both fittings are acceptable, we do an over the lens refraction and convert as per vertex conversion table, and any stain on the conjunctiva is not acceptable. And this is a video where you can see the central fitting of the lenses. We look for the reservoir, which is stained with fluorescein, and it should be anywhere between 200 to 400. This is showing an ideal central fit, and this is a third diagram is showing the different position, vault position of the lens. It should not there should not be too much of reservoir, not too less, causing the corneal touch. And this is an objective method to assess the central vault using AIOC2023. And for the peripheral fitting, we look at the blanching of the conjunctiva. This is a picture showing the correct lens insertion, and this is also an ideal lens landing, but this is an incorrect lens insertion which causes a conjunctival blanching. So this is a lens by the Col.Rangachari Laboratories we used in our study, which had a diameter of 14.5 mm. So a full day trial was done and multiple trials were done, and once the fit is confirmed, the lens is ordered. And we recorded the number of visits as well as we gave the click questionnaire to patient on day 1, 1 month and 6 months to be filled. And also we recorded the mean comfortable wear time. And these are my results. And it was almost 69% of the patients had keratoconus, and 75% of the patient nearly took 2 visits to achieve a correct fit. And when we look at the association between average central keratometry and the number of visits, we saw that patients with higher keratometric values, they needed more visits to achieve a correct fit. And when we see the best corrected visual acuity with corneoscleral lens, it was 0.14 when compared to the mean baseline best corrected visual acuity or 0.5. And in 85% of patients, there was no complications. And when we see at the questionnaire, the contact lens impact and quality of life questionnaire, the row score and the percent measure, it was statistically significant between day 1, 1 month and 6 months. And coming to the discussion, the corneoscleral lens seems to be an effective option, especially in corneal ectasias causing irregular astigmatism. And our study showed a statistically significant improvement in visual acuity, and also like the patient with an average central keratometry value of about 70 was able to tolerate this lens. So we can infer that it was a feasible option for even with higher keratometric values. And the mean comfortable wear time of the lens was around 7 to 12 hours, that is around 10.3. And the average total score obtained during the question, using the question on day 6 months showed a positive correlation, which is statistically significant. And that indicated that the patient was satisfied using the lens at the end of 6 months. So to conclude, to the best of our knowledge, no previous studies have assessed the fitting, complication, and patient satisfaction with corneoscleral lens in a sample population in India. So it will be an effective option, providing a good visual acuity and an optimum visual quality in patients with irregular astigmatism. So the limitations are a smaller sample size and a short-term follow-up. These are my references. Thank you for your patient listening.
I have a question to you. Like you have mentioned in your topic as quality of life, you have not shown anything like functional disability and the functional benefit. So how did you assess the quality of life? Because the topic says it's both on visual rehabilitation
So
and
it was using a questionnaire, that is a contact lens impact and quality of life questionnaire, which is a 28 item. 28 questions were there, which was given on patient on day 1, then after 1 month, and after 6 months. So in that questions, that's with the help of that questionnaire, we assess the quality of life.
Have you shown what is the functional disability and the functional benefit in the quality of life? Because that has not been shown in the results, and how will we know that the quality of life has improved?
Because the row score and the person measure is one that, ma'am.
Just one more question.
Yeah.
Did you compare with the Boston Prose lens? Because that's the other corneoscleral lens that's
No, sir.
commonly used.
We tried with corneoscleral lenses only.
But you
No
didn't compare
comparison was not there, because in corneas with very high keratometric values, since CSL had a clear advantage. So no, after fitting, no one was. Patient with C3R also had we fitted this. Yeah.
Thank you.